Assalamu alaikum wa rahmatullah. We made it to the last part of this lecture, which talks about the disorders of the TM joint. And as we discussed earlier, and as you can see here, this shows the problem of disc displacement with reduction. And with reduction, it means that as the disc is displaced, and when you try to open your mouth, it clicks and it reduces back to its place. So it reduces with reduction, it means it reduces back to its place, or it goes back to its place. And then it might, and so you can open normally, no limitation mouth opening, and then it slides back to its abnormal place, the abnormal dislocated place or displaced anteriorly, or to the abnormal anterior side if it is displaced anteriorly. In some patients it does not go smoothly and it clicks back, producing a reciprocal click. So there is no limitation mouth opening, but there's sort of, it got stuck initially and produces a click. Then the patient would be able to open. In most cases the click is not painful. The patient is not complaining of the click. However, in some patients they might have a painful click. They it's irritating. The click is sort of painful, particularly if it is displaced significantly anteriorly. Some patients have sort of intermittent click. Does not click every time the patient opens his mouth. It clicks sometimes. And some patients have intermittent locking, which means that in some instances the disc, the patient cannot open his mouth, the disc does not reduce back to its place, and the patient had to move it or click it so that he can open. So we call it disc displacement with reduction and intermittent locking. This is the normal joint here. This is how the disc moves with the joint when it opens and when it closes. But in disc displacement, you see here the disc is distorted structurally and is displaced anteriorly, more displaced anteriorly, and it folds when the patient tries to open his mouth, and it clicks back to its normal place. This if you compare this with disc displacement without reduction, usually the disc is displaced further forward, and now when you open the mouth, the joint cannot move forward because it is stuck. This is the joint, this is the disc, and it is stuck, and it cannot the disc cannot reduce. So we call it disc displacement without reduction, and it is associated with the limited mouth opening because the joint is stuck and the patient cannot open his mouth, and usually also associated with pain because now the patient is pressing on the retrodiscal tissues, which are highly vascular, highly innervated. The patient would come to you, tell you that I used to have a click in my joint, then my joint stopped clicking, but I cannot open my mouth properly. So this is how it happens. We usually diagnose it clinically just by listening to the patient's story, by doing the examination, noting the limited mouth opening, noted the deflection, so the jaw would deflect. So this cannot translate. For example, there is locking in this jaw, so this would translate completely. So now the patient can, when opened, let me do the other side. So this is the jaw that is locked, and the patient the jaw cannot translate forward in this side, while in this side the jaw is normal and the disc is in the normal place, and the patient can move freely. So when the patient opens his mouth, both would rotate, this would translate, but this cannot. So the patient, there's a deflection to this side. So the patient would try to open, there's a limitation in the mouth opening, and there's a deflection. So this is how we do it. We diagnose it clinically. However, some patients have sort of chronic problem, and there is a chronic limitation in the mouth opening, and we need to confirm the diagnosis. We need to take MRI. So to visualize soft tissues and the bone, we need to take MRI. Taking pano or CT is not useful in this condition because we would not be able to see the disc that we are examining in the first place. So so this is an example of MRI, and you can see here, this is the joint, this is the disc here, these are the retrodiscal tissues, and you can see here the disc is displaced anteriorly, and here this is the articular disc, and you can see it is a ribbon shape. It will appear black in color, and this is when the patient closes his mouth. It went back, or it goes back, it reduces and it goes back to a normal position. So it was displaced anteriorly when the patient is closing his mouth, and when the patient opened his mouth, so the joint has slided or translated forward, and this is the eminence now, and the disc managed to reduce and goes back over the joint. So we do take MRI to confirm the diagnosis. So this is regarding internal derangement, disc displacement with and without reduction. The second type of problems that we can see is inflammatory conditions, including capsulitis, retrodiscitis, and degenerative changes. Here, showing detailed anatomy of the joint. You see a healthy bone, a healthy joint. This is the disc, ribbon shape. This is the posterior and anterior parts of the disc. And this is the retrodiscal tissues, which are highly vascularized and innervated. This is the superior and inferior lateral pterygoid. The superior is attached to the disc, as you can see. So this is the normal presentation. In osteoarthritis is a degenerative disease, and it would affect the jaw. The joint, it will affect the joint, and usually it affects female patients over 50, and there is destruction of the joint, as you can see. The disc is also destructed. Usually just remnants of the disc would be left over in a torn, abnormal, stretched appearance, and there is a destruction of the bone, not just restricted to the joint, but also to the fossa and the eminence as well. And it is, as I said, degenerative changes, so there is no autoantibodies. It's not rheumatoid arthritis, so the rheumatoid factor, the ESR, all are normal. And this is how we see it in the radiograph. We see a lipping, we call it a lipping, or osteophyte that is present on the jaw instead of being round and corticated. So this represents the changes that might occur on the joint, decrease in the space between the joint and the fossa. So all of these are features of the degenerative changes. Sometimes the osteoarthritis can be so severe, as you can see here. There's severe destruction of the joint, and it is bilateral, it is in both sides. Right, rheumatoid arthritis, again, there is a destruction of the joint. It is an autoimmune disease, so there is autoantibodies, and we can see increase in the rheumatoid factor, and in other immune tests are done to confirm the diagnosis of rheumatoid arthritis. There is a family history usually, and it can affect children or young adults in juvenile rheumatoid arthritis. The difference, or one major or big difference, is that in rheumatoid arthritis there is sort of a swelling in the acute phase of the joint inflammation because of of the autoimmune nature of the disease. And if the disease was not treated, it will end up with a complication called ankylosis, where there is excessive destruction and abnormal repair of the destruction, leading to ankylosis and bone formation that joins the joint with the fossa, leading to a limited mouth opening. So the third problem is hypermobility, which could be subluxation or luxation. They are actually the same, but luxation is more severe than subluxation. In subluxation, both the condyle and the disc, the whole complex, moves beyond the articular eminence. So normally it is seated in the fossa, and when the patient opens his mouth, it goes up to the eminence. But in those patients, because of the hypermobility, this complex, the joint disc complex, would go beyond the articular eminence, and the patient would hear a thud sound. Sometimes the clinician cannot tell the difference between a subluxation and a late click. And in this patient, although it goes beyond the eminence, but still he can put it back and return it back to normal. In luxation, as the joint and the disc complex, they go much more anterior to the eminence, and therefore the patient would not be able to return it back to normal, and he had to see the doctor to do it for him. So this is a TM joint subluxation. So this is the normal location when the jaw is closed. When you open, the joint would rotate and then translate. Usually it should stop here at the eminence level, but in subluxation, because of the laxity of the ligaments, the jaw can move beyond. The joint can move beyond the eminence, but still the patient would be able to push it back and return it back to normal. In luxation, it is hard for the patient to put it back, and he had to see the clinician where they reduce it for them. I'm not sure if I have the image. No, I do not. They reduce it for the patient by putting pressure on the posterior molar teeth and moving downward and backward to return the joint to the fossa. The treatment of hypermobility is just ask the patient to avoid wide opening, and when yawning, just to put his hand under the chin so he to prevent his mouth from opening widely. If this was not enough to control the problem, we do Botox injections to the pterygoid muscles, to the lateral pterygoids, to paralyze it and weakening it so it would not open widely. And sometimes surgical treatment would be indicated for persistent cases by doing eminectomy, like removing let me check here, by removing the eminence here, so the jaw would not get locked. It can move forward and backward freely. Okay, hypomobility is the opposite. So there's limitation in the mouth opening, and this is really caused by ankylosis. Could be fibrous or bony ankylosis. The fibrous ankylosis is far much more common than the bony ankylosis, and usually it results from trauma, mainly when the patient had a blow on his face or got a concussion trauma that leads to bleeding in the jaw. Healing would occur or would take place by doing fibrosis, and this will lead to a fibrous ankylosis. If the limitation in mouth opening is not severe and the patient can function normally, there is no need for any treatment other than explanation to the patient what is going wrong and what's happened. If there is excessive limitation, then treatment is indicated, usually surgically. Bony ankylosis is far much rare. It used to be secondary to infections to the joint, when there is open wound or for any reason there is an infection that spread to the joint, managed to spread to the joint, this would lead to ankylosis. Now, as there are, we use antibiotics a lot, this condition is not seen commonly, and the only treatment for it is open joint surgery. Sorry, here. So this is an example of bony ankylosis. You can see here lots of bone, highly sclerotic bone is joining the joint and the base of the skull. And this is the cone beam CT showing 3D image of the joint fused to the base of the skull here. Right, how to deal with the TMD or TM joint problem. It depends on the condition. Usually, or most of the cases, would respond to reassurance, educate the patient about the condition, what does it mean having a click, what causes the click, and usually it is treated by avoidance therapy we described earlier, using NSAIDs if there is pain. If the problem is accompanied with a muscle problem, we can prescribe muscle relaxant. Physiotherapy and jaw exercises and occlusal splint are really useful to reduce or unload the jaw, and this is the example of the stabilization splint that we use. It is a hard acrylic and the surface should be flat so that should be flat, so there is no encouragement of the teeth, of the jaw to clench on the same position. So if you have the same structure here, the same anatomy of the teeth, it's useless. So it needs to be flat. First, it will prevent the jaw from clenching at the same position, and this usually lasts for up to 2-3 months, but later having the flat stabilization splint would manage to distribute the load on both joints and reduce the loading generally on the joint. If the problem is inflammatory, so we need to first describe NSAIDs. If this is not enough, we'll do steroid injections, trigger point injections for the muscles. If there is myofascial pain, sometimes the patient might need occlusal adjustment, or if there is open locking, as in the case of hypermobility, subluxation or luxation, mainly we do manipulation under sedation. Antidepressants are prescribed for muscle pain, chronic muscle pain, so they are usually managed with antidepressants because they have a muscle relaxation activity, not because of their antidepressant action. So usually the dentist is capable of doing this initial or conservative treatment, and most of the patients will respond very well to this treatment. And some resistant cases need to be referred for specialists to conduct these procedures to treat the condition. So that's all regarding the TMD. Hope this is useful and you can apply it in your clinic. Thank you very much and see you next lecture. Bye-bye.